For our presentation, we chose the obsessive compulsive disorder out of our section. And in our group today is Katie, Caitlin, Faith, and Mackenzie.
So starting off with the basic identifying information of obsessive compulsive disorder, the symptoms and diagnostic criteria of OCD according to the DSM-5 includes presence of obsessions, compulsions, or both, recurrent and persistent thoughts, urges, or images that are experienced at some point during the disturbance as intrusive, unwanted, and that in most individuals cause marked anxiety or stress, attempting to ignore or suppress thoughts, urges, or images with another thought or action. Repeated behaviors or mental acts in response to an obsession, and examples of repeated behaviors would be hand washing, order checking, praying, counting, repeating words silently. Behaviors or mental acts that are meant to prevent or reduce stress or prevent a dreaded situation, although these mental acts and behaviors do not correlate in a realistic way or are excessive. And the obsessions or compulsions are time consuming, which the definition of time consuming for the purpose of diagnosing OCD would be an hour or more per day or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And that would be like the amount of time total spent, not just total on one action. And then we do have a visual as well to share that just goes into a little bit more depth on the basics of OCD.
Double checking things is a pretty common human behavior. Like, did I shut the garage door? Better double check. How about locking the front door? Double check. Gas stove and oven off? Double check. We all do it. But what if you feel compelled to triple check it? Or even quadruple check it? Or quintuple check it even? Then it might be considered an obsession. Now, what if you have to do a certain ritual with the gas stove and oven before leaving the home each time? Like, make sure the gas stove is off, wipe down the gas stove to clean it, double check that the burners are off, make sure the oven's off, wipe down the oven to clean it, and then open the oven door to make sure no heat's coming out. And then you can leave the house. Then that might be a compulsion. Obsessive compulsive disorder, or OCD, is a specific type of anxiety disorder characterized by these obsessions or compulsions. Obsessions are recurrent and intrusive thoughts that are typically unwanted and tough to get out of your brain. These unwanted thoughts, like my house is unsafe, cause anxiety, and usually they lead to compulsions, which are actions that might be performed to try and reduce the anxiety associated with obsessions. As you might imagine, these thoughts and rituals can have a serious impact on someone's daily life. OCD affects around 3% of the population and affects both men and women equally, and usually starts in childhood or in the teen years. Celebrities like David Beckham and Howie Mandel are known to be affected by OCD, and a more severe example is that of Howard Hughes, business tycoon and entrepreneur, among other things, who was affected by a relatively incapacitating OCD later in his life. Although obsessive compulsive includes both obsessions and compulsions, one doesn't need both obsessions and compulsions for a diagnosis. Some individuals might have just obsessions or just compulsions, but the majority of patients have both, often where the compulsion is performed to alleviate an obsession. A very common compulsion is cleaning, which often stems from an obsession with germs or contamination. Another common compulsion is checking, usually because they have obsessions that something's unsafe, so they'll check to make sure that something's definitely safe by unlocking and relocking it, sometimes several times. More generally, though, repeating is a compulsion on its own, where an action or phrase is repeated several times. And usually this is done because if it's not, they think something bad will happen. Sometimes patients might feel compelled to order or arrange things, because when they're out of order, it causes anxiety and discomfort. Finally, mental rituals are also obsessions. These are often done to try to neutralize intrusive or what they think are bad thoughts. So they might try and call up specific words or phrases they think are good thoughts to try and replace the bad thoughts. Now, the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition, or the DSM-5, gives specific diagnostic criteria to meet for a diagnosis of OCD. First and foremost, they need to have the presence of obsessions, compulsions, or both. Makes sense. The obsessions and or compulsions need to also be time-consuming, often such that it produces distress with their social life and their work. For example, taking 2 hours every day folding and unfolding clothes and then being late for work. It's also important that the obsessions and compulsions are not due to the physiological effects of a substance or other medical condition. Finally, the apparent anxiety isn't better explained by another mental disorder, like, for example, an obsession with personal appearance, like in dysmorphic disorder. Like most mental disorders, there isn't a known cause of OCD, though it's thought to be a combination of genetic and environmental factors. Sometimes OCD seems to run in families, and an important clue is that identical twins are more often affected than non-identical twins. It's now thought that abnormalities in serotonin neurotransmission in the brain plays a key role, though the exact mechanism is unknown. Treatment usually involves psychotherapy, medications, or both. Among psychotherapy options, cognitive behavior therapy has been effective, specifically a technique called exposure and response therapy, where patients are first exposed to the anxiety and compulsion-provoking situation, ultimately showing that the anxiety actually lessens when the compulsion is not carried out. Because the cause has been linked to serotonin, selective serotonin reuptake inhibitors, or SSRIs, have been shown to be an effective drug treatment, though they often come with symptoms and side effects that may need further treatment with medications or psychotherapy. With the right treatment, though, patients often return to normal daily life and activities.
Okay, so I'm Mackenzie, and I'm going to tell you guys a little bit about the prevalence of OCD. OCD affects around 2 to 3% of the United States population. Lifetime prevalence of OCD among U.S. adults was around 2.3%, and OCD can affect men, women, and children of all races, ethnicities, and backgrounds. Some people may have some symptoms of OCD, but they might not meet the full criteria for this disorder. Slightly more women are diagnosed with OCD than men. Around 1.8% of the diagnosed population are female, and around 0.5% are male. The symptoms of OCD generally occur in childhood, adolescence, and young adulthood. Comorbidity of OCD. So anxiety and depression disorders are the most commonly related to OCD. Historically, relationships with anxiety disorders have been strongly demonstrated by OCD's placement among anxiety disorders. However, with many OCD presentations extending beyond just anxious states. Anxiety disorders that may occur with OCD include separation anxiety disorder, generalized anxiety disorder, panic disorder, social anxiety disorder, and specific phobias. Other comorbid disorders of OCD may include ADHD, autism, eating disorders, and PTSD, but I've saw quite a few studies that said there needs to be more research done on comorbidity of OCD. Cultural considerations. Some patients may experience obsessions and compulsions related to culturally specific taboos, religious rituals, and superstitious beliefs. Compulsions can take on the form of religious rituals or superstitious behaviors, which may be challenging to identify, as these behaviors are often encouraged within the cultural context. Stigma. OCD is often trivialized with jokes being made at the expense of those who have a painful experience. People tend to believe that OCD is a helpful disorder that means clean or organized. And I actually included this image right here because I feel like these are all words that we have heard when people are trying to describe OCD. Like if someone wants to say, I'm quirky, as this image shows, they will say something like, oh, I'm so OCD. But that's not really quite correct. Even companies have used the term OCD in a way that increases stigma in order to gain a profit at the expense of those who suffer from OCD.
So here we have one standardized assessment measurement. This is the DSM-5-TR self-rated level 1 cross-cutting symptom measure for adults. So this would be the first assessment tool used during initial screening. So this could be used with a clinician and or again self-reported before a session, or if there is some suspicion of OCD symptoms, but it's also used just as an overall kind of capture of what the client is experiencing. And it just gives a well-rounded scope of kind of what the client is going through and the symptoms that they're feeling. So if we look at section 10, if the client in this section scores high for the repetitive behaviors and thoughts, then the clinician will then go and use the level 2 assessment tool. And so the two questions in category 10 are 16 and 17, which are unpleasant thoughts, urges, or images that repeatedly enter your mind. And then the client would rate that from 0, not at all, 1, slight, rare, less than a day or 2 days, 2, mild for several days, 3, moderate, more than half the days, 4, severe, nearly every day. And this is over the past 2 weeks. And then 17, feeling driven to perform certain behaviors or mental acts over and over again. And again, that same rating for over the past 2 weeks. So if the client scores a rating of mild, which is 2 or higher, on any of the domains, but we're going to focus on OCD, then there is a push or validation to assess for additional assessments and additional symptoms. So if we want to look at this is the level 2 assessment of repetitive thoughts and behaviors, again for adults of 18 or older. So this assessment tool would provide the client or the clinician to further assess for a potential OCD diagnosis from the level 1 scores. And so the differences that we see in this assessment here, the first difference that we see is there are more questions, but they are more focused and not very broad. So these questions are then completed as they have indicated on the previous assessment that they have been bothered by unwanted repeated thoughts, images, or urges, and being driven to perform those behaviors or mental acts at a mild or greater level of severity. The other difference that we see here is during the past 7 days. So we went from 14 days to 7 days. And so here there are 5 questions. The first question is, on average, how much time is occupied by these thoughts or behaviors each day? And this rates by hours. So 0 is none, 1 is mild, less than an hour a day, 2, moderate, 1 to 3 hours a day, 3, severe, 3 to 8 hours a day, 4, extreme, more than 8 hours a day. The second question here is, how much distress do these thoughts or behaviors cause you? 0 is 1, 1, mild or slightly disturbing, 2, moderate, disturbing but still manageable, 3, severe, very disturbing, and 4, extreme, overwhelmingly distress. Question 3, how hard is it for you to control these thoughts or behaviors? 1, 0 is complete control. 1, much control, usually able to control thoughts or behaviors. 2, moderate control, sometimes able to control thoughts or behaviors. 3, little control, infrequently able to control thoughts or behaviors. 4, no control, unable to control thoughts or behaviors. Question 4, how much do these thoughts or behaviors cause you to avoid anything, going any place, or being with anyone? And so again, that 1 through 4 scale of no, mild, moderate, severe, and extreme. And then question 5, how much do these thoughts or behaviors interfere with school, work, or your social life or family on that 0 to 4 scale. And so if we want to look at the score in order to assess, we take that partial raw score, which is all of those individual numbers added up into one sum, times the number of items. So here is 5 because there's 5 questions. And then you divide that over the number of items that were actually answered. And so it is typically 4 or 5 is the denominator. If the client has skipped 2 or more questions, then there is a strong discouragement of calculating those scores, and it provides a inaccurate score of what the client is experiencing. So if the result is a fraction, then you would round to the nearest whole number. If the individual scores 8 or higher, there should be a considerations for a more detailed assessment for obsessive compulsive disorder. So these two assessments are not direct assessments to diagnose OCD. It's just those beginning workings, those standardized assessments that are used in order to then determine how severe those symptoms are. The next assessment that I'm going to show you is widely used, but it is not used through all clinicians. To diagnose directly is really up to the clinician of which tool that they decide to use. So this is the Yale-Brown Obsessive Compulsive Scale. This is just the first page of the adult version. So this assessment tool is one of many direct assessment tools to diagnose OCD used by clinicians. Like I said, so there is an assessment for adults, which is 18 to 85 years old, and children, 6 to 17 years old. The administration of this assessment is completed by a clinician-administered interview with the client, scoring their feelings, thoughts, behaviors over the past 7 days. And so this assessment tool is actually I provided a link in there. It provides the adult and the child version. And so it's a whole packet, and it shows you how to score. It shows you how to the research that's done on it, the case study. And there's, I would probably say, 4-ish or so sheets of questions per assessment. And then these assessments are used in practice. It truly depends on the clinician. The first one can either be self-rated or done with the clinician, but the other two are definitely done with the clinician. And again, these are just to assess how severe, how frequent, things of that nature of the symptoms.
All right, so I'm Katie, and I looked at the evidence-based protocols that are used when somebody is diagnosed with obsessive compulsive disorder. And the first one I found were medications. Selective serotonin reuptake inhibitors, or SSRIs, have been proven by research to be the most effective for OCD. And some examples of these would be Zoloft, Prozac, Paxil, and Luvox. Because depression can be comorbid with OCD, which we talked about earlier in the presentation, SSRIs are used to treat both the depression and the OCD. That does not mean that all SSRIs treat OCD. Some only treat depression, so you definitely have to talk to your doctor about it. And if the SSRIs are not enough, some doctors will prescribe antipsychotics to go along with the SSRIs. And those could include Abilify, Risperdal, Seroquel, and Zyprexa. And the medications must be taken regularly as directed. Many people might have issues with side effects, so that's definitely something that clients should talk to their doctors about. And then they can deal with where to go from there, whether changing the dosage or getting on a different medication. And then another evidence-based protocol that I found is a type of cognitive behavioral therapy, and it is exposure and response prevention. And in this, the exposure would be confronting the thoughts, images, objects, and situations that provoke anxiety and obsessions in a safe, controlled environment. So this would be done in a therapeutic setting. And for example, a client would go in to talk to their therapist about their exposure might be the germs or feeling unsafe. And then the responsive prevention part is making the choice not to feed into the compulsions or anxiety that have been triggered by the exposure. So those feelings that people get to do their compulsions when they've been exposed to anything that makes them anxious, and to start, cleaning or turning on and off the lights a certain amount of times. What they can do to not do that, they do that in therapy. And then once they retrain their brain in therapy, they can start taking it home and doing it by themselves there.
So our active participation is a quiz. So for our piece, we have a 7-question quiz, and we're also asking you to make 2 additional comments. Question 1, fill in the blank. OCD is the blank most common mental illness. Question 2, true or false? Men are more diagnosed with OCD than women. Question 3, multiple choice. What is not a comorbidity of OCD? A, generalized anxiety disorder. B, specific phobias. C, autism spectrum disorder. D, kleptomania. Or E, panic disorder. Question 4, fill in the blank. What did the image say? OCD is not in blank. Question 5, what is the minimum score on the cross-cutting level 1 assessment for a clinician to move to the level 2 assessment? Question 6, true or false? The level 2 assessment is a direct assessment to diagnose OCD. And question 7, which is a short answer, what does ERP stand for and what theory is it based off of? And so we ask that you put those answers in your comment on the discussion board post, but we also ask you to please answer these 2 additional prompts. So what prior knowledge did you have about obsessive compulsive disorder? And then what piece of information did you learn from the presentation? And here are our references.
Thank you for watching.